So our first case is a febrile seizure over at Georgetown ED, where I work. We have a 1-year-old male. It's up to date on all his vaccines for age. He's had 1 day of fever, runny nose, cough. He had a generalized seizure under a minute at home. Once he's in the ER, he has a rectal temp of 38.5 and is back to his baselines. No focal neurologic findings on exam. Our second case, closed head injury over at MMC. 3-year-old female, witnessed to have fallen down about 6 steps. She did not lose consciousness, not been vomiting. Is a GCS 15. She's also at her baseline without any deficits. And the only positive physical exam finding you see is a big old forehead contusion. Our third case, appendicitis at St. Mary's. We have a 9-year-old male, no significant history, no surgical history, had right lower quadrant belly pain, nausea, vomiting, getting worse for the past 2 days, not eating great, no systemic symptoms or genitourinary symptoms, and he's focally tender in the right lower quadrant without peritoneal signs. So advanced imaging in our ED-PEDS patients is a really important topic, and it's been estimated that about 1 out of 4 pediatric patients receive imaging of any type in the ED setting. And we're defining advanced imaging as ultrasound, CT, or MRI. And in regards to the AAP policy statement, just to clarify, this did not include and does not comment on point of care ultrasound by ED providers. So nationally, imaging has really increased for Peds ED patients without improvements in their outcomes shown. And multiple studies have shown that advanced imaging of our Peds patients in the ED is really providing low value care and that the risks are exceeding any benefits to our most vulnerable patients. We're all really familiar with the potential risks of advanced imaging in our kids, but let's just go over them briefly. So, horse harm from potential radiation exposure. Then you have risks of sedation if needed, risks of potential allergy to contrast, exposure. Just placing an IV has its own risks. And let's not forget the anxiety of the test itself, performing the test, parental anxiety due to potential misreads or those incidental findings. And really, there's high costs to the patient and the healthcare system. Imaging can potentially lead to delay in patient care and greater impacts on the entire ED and throughput, and already putting additional stress onto our tax system. So several initiatives have tried and trying to tackle this issue, including, you may have heard of the Choosing Wisely campaign, put out some recommendations on reducing imaging in our patients, and also the Image Gently Alliance. The American College of Radiology also has provided their own imaging guidelines for many pediatric conditions. So as a result of research and recommendations from these various stakeholders, the AAP published their policy statement in June of this year on the best use of advanced imaging in the ED for our PEDS patients. And let's dive right into kind of highlights from the policy statement and how they relate to our 3 sample cases. And I really recommend, if you have some time just on your own, to really read through the policy statement. It's not long, it's only about 7 pages. Even to consider reading on your phone and taking screenshots of these tables to keep in your notes section. I did that and I find it helpful to use in real time. So with our first case, the simple febrile seizure, the AAP is recommending that neuroimaging is not necessary for children with a simple febrile seizure. Even though this wasn't one of our cases, but we see this quite often, afebrile seizures, they recommend not ordering emergent imaging, talking about that emergent CT for kids 6 months and over with an unprovoked generalized seizure, with the caveat that they are back to their baseline mental status and no, neurologic deficits on exam. And actually for patients with kind of breakthrough seizures, known epilepsy, similarly, not recommended because they're back to their baseline and no abnormal neurologic. For our second case, head trauma, Dr. Teferi is going to talk to us soon about risk stratification tools. The AAP recommends using these in your decision making, and the recommendation that CT scans are not needed for mild head injury. For our third case, the appendicitis, again, using those risk stratification tools. First line, if available, ultrasound. We'll talk about some potential real-life challenges with that. And alternatives to consider, MRI without contrast, your CT, considering repeat ultrasound 6 to 12 hours later, a period of observation. So it's really important to kind of acknowledge real-life challenges you're all probably thinking of with these recommendations. First off, access, peds radiology readings limited, many sites, ultrasound availability. And let's not forget the operator-dependent nature of our ultrasound. Rapid MRI for VP, for shunt failure, for appendicitis. Dr. Zandieh and I worked a few years back to kind of get this started. Use that often at Georgetown, plus or minus depending on the provider, but that's also limited availability at many of our sites. Let's not forget about that recommendation here of observation for appendicitis or closed head injury as well. That can lead to real significant delays in ED throughput and potential even more risk to the patient from being in the ER longer. And really something I want to highlight is very important real life challenge is considering the emotions of parents, caregivers when their child is ill or injured. So a little personal, but my son, he's 15, he did give consent to share this with the group, but about 10 days ago, he was hit by a car while jogging in a crosswalk here in DC. We think it was low speed. He fell, he did, hit his head. He had a large posterior scalp hematoma. We don't think he lost consciousness, but it was a little muddy. So when we convinced the EMTs to let us transport him ourselves over to Georgetown, I mean, there was no way anybody in the ER was going to convince me not to do a head CT on him. And I knew that if we didn't do it, I wouldn't be sleeping for weeks worrying I'm missing subtle signs that he did have a bleed, acknowledging many of bleeds in kids, especially are non-operable. But we really have to consider the parents' emotions as well. And thank you to Dr. Zandieh and Dr. Furlong if he's on this call for taking great care of him. So as providers, we can really kind of do our best to share the stats, our medical experience, but really too important to consider the emotional state of the parent. And not only that, your mental well-being as a provider, that waking up in the middle of the night, should have done a CT, or even the other way around, I shouldn't have done the CT, the kid's going to have cancer really down the line. So, the best we can do is use these recommendations and do the best that we can. So I'm going to stop sharing and hand this over to Dr. Teferi now.
Tammy, before we transition, can I ask you a couple questions? So I'm curious, did you use a risk stratification tool at all with your son?
Yes. She's going to talk about Dr. Teferi P-card, and of course, I mentally went through it. And the guideline was more of a recommendation of observation period. But
yeah,
emotions were a big part of it.
I get it. And when I hear you go through that list, the one that really strikes me is the new onset seizure in an afebrile child. I wonder if you can just talk about that a little bit more. So the recommendation in a afebrile new onset seizure is to not get emergent head imaging. Am I hearing that right?
Yes. So when we look back at research on this, acute findings that we're going to change anything in the acute period on a head CT were really not found. There is a recommendation, though, that as an outpatient, if it's like a new afebrile seizure and the patient hasn't already had workup for seizures, and neuroimaging to do an MRI is the study of choice for those patients. Better to look for mass or things that a head CT wouldn't be great for anyways.
Yeah.
Okay, great. So we want to talk about a little bit about clinical decision support mechanisms, as there are constantly new guidelines and best practices that are coming out. What is the best way we can keep ourselves up to date in a way that is embedded into the practice, embedded into our EHR? So with that comes clinical decision support mechanisms, and we'll go through some examples of some of those that we have available at MedStar and just on the web as well. So computer alerts and reminders. We've talked about clinical guidelines like the one we're reviewing today. There's condition-specific order sets, documentation templates, as we're all aware of those, diagnostic support, and then reference information. So condition-specific order sets, we are currently, this is a great example of one that we are working on at MedStar with St. Mary's and Dr. Zatari's group. Children's National has 80 pediatric order sets, and they have come to us because 80% of pediatric patients are actually taken care of not in academic children's hospitals. They're taken care of in the community. So they would like to see how they can improve the care of children through condition-specific order sets. So we started with asthma at St. Mary's, and we've adopted, since Children's has Cerner as well, we've adopted the asthma order set that they have that has decision support in there. And we are measuring the bounce back rate, the transfer rate, and length of stay in the ED pre and post implementation of this particular order set. So we will have, we should be able to hopefully share that data with you guys. And we're hoping that if this is successful and the order sets are being used and it makes people more comfortable with tackling pediatric diagnoses, that we hope to roll out more diagnoses and system-wide as well. That's the hope. So our next one is diagnostic support. And I know that all of you have seen decision support embedded into the order set, right? So when you are ordering a CT scan or an MRI, there's going to be several questions that ask you if this is the appropriate modality. MD Calc is another app that is available on the web that has several actually pediatric specific tools and that you can use for decision making. We're going to review the pediatric head injury one. They have an appendicitis one. They actually have 3 for appendicitis. And then in our own EHR, through the ad hoc buttons, you can do the PCAR and head injury and embed that into your notes. So we'll go through those. So here's an example of the pediatric appendicitis score. And as you can see, it tells you what ages you can use it for. And very, very simple yes or no questions, right lower quadrant pain, anorexia, fever. And then the next set of questions, nausea, vomiting, tenderness, leukocytosis. So all of these will give you a point or 2. And when I played around with it a little bit, if a score of 6 or 7 will get you a pretty firm diagnosis of appendicitis. This is an example of what the ad hoc note looks like. You guys, we do ad hoc all the time. You click on ED physician, and then there is a pediatric head injury note that you can click on, and this is what it looks like. So here it'll ask you, is this a head injury? And then it stratifies to less than 2 years old, over 2 years old. And then you basically answer the first 2 boxes, and then it'll tell you whether the head CT is indicated or not. And it's actually, I've played around with this as well. And you really need a high mechanism of injury, loss of consciousness in order for the head CT to be indicated. And then this can get embedded in your note under procedures. So to talk a little bit further about MedStar hospitals, we all have very different resources in terms of what we are capable of doing. Dr. Katy has some resources. I have a little bit less than she has at MedStar Montgomery. So it's really important to kind of think about and know, like, to know ahead of time what your resources are at your particular facility, right? So one thing we wanted to touch on is there pediatric specific protocols for imaging? What is your surgeon's age cutoff? Or is it a cutoff at 12? Is it 14? Do you have pediatric anesthesia, or do you have anesthesia that may not be pediatric, but they're very comfortable with pediatric patients? And nursing, what is your nursing staff comfortable with? Not all nursing staff are PALS certified, so you really need to keep an eye on that and know that for your own facility. And then you also want to know and make sure that you really ask some good questions about children with special conditions. Even if the age cutoff might be okay for that particular surgeon, you want to make sure that the child has no underlying conditions that might require them to be in a facility with higher level of care. As Dr. Katy mentioned, shared decision-making is very, very important. In my personal experience, you're never going to be wrong in transferring a patient if you don't feel comfortable. That is never going to be a wrong decision. I think you always have to have the conversation with the family and let them know that you might be you're sending them for this particular reason, and they might get there and the evaluation is negative and they get to go home, but that's the best course of action given the alternative that your facility can offer. And then there's always transportation to consider, right? We don't always have access to get a child to another facility. Do you send them by private car? Do you send them in an ambulance? So that also comes into play. And then again, the higher level of care. Several of us do have the option for observation in our facility. I'm able to do that at MedStar Montgomery. I know that Georgetown is able to do that, but not many other facilities are able to do that. So yeah, so we just need to remember that as our own limitations and do what's in the best interest. And then imaging first versus transferring. So in the policy statement, there's also a very nice table that talks about should you image first versus transferring and letting the imaging be done at the receiving hospital. So if it's an emergent situation the imaging will assist with determining whether emergent intervention is needed, then yes, you should image that person, right? If the imaging will assist with determining whether transfer is needed versus the child may or may not be able to go home, then you can also image that patient there. The caveat to that is if it is something like child abuse and they need a skeletal survey, they need a child abuse team, I would advocate that we not do those in our facilities, and those need to be sent where there's a child protection team, because the skeletal surveys need to be done a certain way with the least amount of radiation, and they need to be read by pediatric radiology, so there's no false reading, because that could have a social, custodial, criminal implication. So I personally feel that those children need to be transferred, even if there's a suspicion of abuse, and go to a facility that can do a very thorough, appropriate evaluation. And then the next one is, will the patient be transferred regardless of imaging findings? So this is probably the one that we deal with the most. In my situation at MedStar Montgomery, I have transferred many children that were suspected of having appendicitis because I could not get an ultrasound at MedStar Montgomery. And I have that conversation with the family, and I tell them there is a study that can be done that is no radiation, but it would require for you to travel. And then we do shared decision making. If they feel strongly they don't want to move, then so be it, and I document that. But most of the parents that I've had this conversation with feel very comfortable going to Children's. I call ahead, I let them know I'm sending the kid, they put it on the board. The other option is to do the imaging. The several times that I've tried to do the ultrasound at MedStar Montgomery, it's inconclusive, and then Children's ends up repeating the ultrasound anyway. So, and then it's time lost, inconvenience, fees, and that kind of thing. So I have just opted to have a conversation with the family to say, I strongly suspect this is what's happening. I don't know 100%, but I feel that this is the better option for you to get ultrasound rather than CT with the radiation. And most families have been totally fine with that. I did want to put in a plug for MedStar Pediatric Telehealth, which is staffed by the pediatricians at MedStar Montgomery. We are available to do consults for all of MEP as well as all the urgent cares. We're available 24/7. From 8 a.m. to noon, we're actually on call. So there is a lot of us do travel during those hours, just so if we don't answer right away, there's a phone number you can call. And then between noon and 8 a.m., it's the physician who's staffing the ED. And here is the slide on how to get access to us. There's a phone number at the bottom and an email to get this set up. The urgent cares do a great job calling. We don't get as many calls from the ED, but we're happy to help. If we don't answer, just call them and ask them to call us directly on our phone line, because they can do that. It might be with a patient with a procedure, but we were happy to help and give you a call back to brainstorm on what's the best way to handle a particular patient.
Sofia, can you please put that phone number for the MedStar Telehealth Peds consult in the chat? That's super helpful.
Yeah.
A couple questions. Sofia, I heard you mention 3 different pediatric scores for appendicitis. Is there one that you prefer?
I haven't used them very much, to be very perfectly honest. I kind of do my own, but I mean, when I've looked at it and was playing with it for this presentation, it's really that I haven't used the other 3, so I can't speak to them, to be honest.
Yeah.
But it's really very much the fever, the right lower quadrant pain, the vomiting. Those are the things that and what the kid looks like, how long it's been going on. Yeah, so that has worked for me. So I haven't used the other one.
I saw a recent study where they were comparing them, Manish, and the conclusion was that the Peds appendicitis risk calculator one compared to the Alvarado and the what's the name on the other one? The pediatric appendicitis score. So the pediatric appendicitis risk calculator seemed to fare better than the other 2.
That's helpful, Tammy. Do you mind putting if you have a link to that specific, not necessarily the article, but maybe just that risk score in the chat, that'd be great. And then if we could just talk a bit more about ultrasonography, and Rocky, you might be talking about this, but my question there is, who has access to it, and is the negative predictive value high enough that we can use it to reliably rule out appendicitis?
Yeah, I can sort of expand on that. So I think it really should be done by skilled operators who know what to look for and are accustomed to scanning for the appendix. So there's a lot of potential pitfalls. Actually, it's not a straightforward type of ultrasound. We're not talking about like a kidney ultrasound that is a routine protocol that is very easy. You can like thyroid scans are really very, very regimented. You should be able to like reproduce the same images, or like a head ultrasound on a baby. There's a fairly uniform approach. The challenge with something like the appendix is it can be in a variable position. I mean, we usually look for specific anatomic landmarks. We look in the right lower quadrant. We try to look for the psoas muscle, the iliac vessels. We're looking for things like the cecal base. But I've seen the appendix be in the right upper quadrant. I've seen it like right next to the gallbladder. I've seen it deep in the pelvis by the bladder, like beneath, like where the bladder is, midline. If the patient is malrotated, it might not even be in the right lower quadrant. So it's more difficult. And there are other potential pitfalls other than the fact that you don't always have a routine location for the appendix. Are things like there are things that may mimic the appendix. It might be the terminal ileum that you're looking at. It might be a small bowel loop. You have to confirm that it's actually the appendix. So the skilled operator will try to document that it's blind ending, and sometimes we can't really confirm that. If it's a retrocecal appendix, we may not see the appendix at all. Portions of the tip can be obscured. We may not see the tip in its entirety. We can miss a tip appendicitis. Portions of the appendix can look normal. And then where the inflamed segment is, you may not appreciate the fact that it's dilated there. So there's definitely features that we look for. Many times we even in the most skilled operators, you may not actually be able to see the appendix entirely. I would argue like the sensitivity and specificity of the ultrasound is much lower than that of a CT or an MRI, obviously. But from personal experience, I would say that my own rate of successfully with high confidence seeing the appendix is probably like only 70%, maybe 70 to 80% if I'm having a good day overall, of being very, very confident. So you need to document blind ending tip, communication to cecal base. There's a lot of things. It's a complicated scan, you know. Some of the features that you look for are echogenic stranding around the appendix. I've found sometimes the sonographer doesn't appreciate the fact that there's fat stranding. Some of the inflammatory changes are not picked up by the people scanning them. And I really think that it should be a physician-driven exam too. You really want the radiologist to be there to supervise and to go in and problem solve these. You don't want to just leave it in the hands of the tech and the tech does all the work here. You know, I think that sometimes when the technologist can't find the appendix, you have another person go in to do the scan, and that's just not available, you know, in the community at large. This is not a widely available approach. So I also wanted to briefly mention when I start to think about an ultrasound being indicated, that I was classically trained to use the pediatric appendicitis score. We had a modified version. They're all very similar. Samuel, Alvarado, Mantrell score, they all use the same parameters, very similar parameters. And maybe the weighting is a little bit different, or the cutoff for what constitutes a white count is a little bit different, or like what is an elevated absolute neutrophil count. But they all have very similar parameters. And for me, like when I was in the process of training, the score above 4 was considered to be like moderate risk. So that was definitely the risk stratification that deemed who needs imaging, right? If their pediatric appendicitis score is less than 4, they don't need an ultrasound, you know. But once you're above 4, you start to wonder, okay, imaging is probably indicated here in this scenario, and also like a surgical consult. And virtually every ultrasound scan that was requested went hand in hand with a surgical consultation. You know, at the major pediatric centers, you're always asking a surgeon to come in too and weigh in on the picture. So, you know, I don't think that you can just approach the imaging in isolation without all of that additional groundwork that gets put into it. So yeah, it's tough.
So Tammy, I wonder if you can close that loop, Tammy and Sofia, and I don't know if this is a reasonable question, but I'll ask it. Should we be using ultrasonography in our EDs, specifically to appendicitis? And I guess I would say outside of Georgetown, because, and Rocky, I'm making an assumption here that Georgetown, of our 9 emergency departments, Georgetown has the best capacity for pediatric ultrasound for appendicitis. Is that fair?
I don't know if that's 100% fair, because we have some great sonographers, we have some great radiologists. I mean, I think our network at large is fabulous, and a lot of our body imagers are very skilled at reading things. If you want to know the truth, sometimes even in the nighttime when we do our own scans at Georgetown, we're still subject to some limitation, because I'm not awake 24 hours of the day, and there's a period of time where we have night float coverage, we have resident or house officers that are doing preliminary reads. Sometimes our technologists at night are, they may be PRN or floating techs, or even our skilled technologists at night, they still don't have that second layer of the skilled radiologists there. And you can still have scenarios where we're doing the ultrasound and we get a non-diagnostic scan. That happens not infrequently. And I would say there are scenarios where sometimes we've deemed an ultrasound to look fairly, we would say that there's no sonographic evidence of appendicitis, and that could be a false negative. Or we might even say that the appendix looks as though there's inflammation, and it could be a false positive. So we still run into those issues even at Georgetown. And the other sites, I don't want to just discredit them as saying that they shouldn't be doing those ultrasounds. I think that there's a little bit more to it than that. But we have good technologists. Regardless of how great your technologists are, you can still run into these issues. Even at Georgetown, we still have that. So I don't know, Tammy, has that been your experience as well?
Yes, exactly.
I mean, I would love to see our ultrasound capabilities improved at the other hospitals, just because I feel like I've tried a bunch of times and I end up sending them out, and they repeat the ultrasounds there. And so I don't know. I think it's a huge inconvenience. I mean, I'm sure even from the other hospitals to go to a children's facility, but even from MedStar Montgomery, it's 45 minutes. It's in DC, and they might get all the way over there and the ultrasound is negative and they go home. I do have that conversation with them, but I do think it's worth doing that instead of getting a CT, especially if it's a 5-year-old, a 6-year-old. I'm less likely to scan those kids.
So I think I'm hearing you all say that it really is case dependent. It kind of depends on who's working, what's available in that moment. Is that right? Yeah. Okay. And Rocky, I wonder if we can talk a little bit about two pieces. One, do we routinely apply dose reduction? And two, do we have pediatric radiologists reading images regardless of where those images are obtained across our EDs?
Yeah, so generally speaking, we are all credentialed at multiple sites. We're able to render teleradiology services, and anytime anyone requests me to look at an ultrasound, I'm able to look at it and dictate it. So that we do add that layer of service. But again, you're not able to go in and scan yourself. It's kind of difficult to sort of problem shoot those times when there's a challenge in identifying the appendix, and short of holding someone's hand, and it's kind of hard. But I think for the dose reduction, that I'm happy to discuss that. There are many strategies for that. If being that we are sensitive to radiation and sort of in our efforts to limit radiation, what Tammy had mentioned earlier, some of the options that we have, a period of observation, repeat ultrasound, I think that's very valuable. Or doing a radiation alternative study other than ultrasound, which is MRI. MRI is not widely available, but we can use MRI. That it is possible to talk about the appendix on the MRI, and it's often quite diagnostic. When it comes to doing a CT, our strategies are to first limit the window of scan, so we can actually just focus where we expect the pelvis to be. We don't really need the CT abdomen to go way up high. Like, we can just scan from the inferior margin of the liver per se through the bladder base. Normally our abdomen scans are a little bit more of a wider field of view, so we can always collimate the area that we scan. And then we also do certain things to reduce dose from the perspective of how we control the X-ray tube that generates the X-rays. So the CT scan uses like a X-ray technology, and we have two major parameters that we use. We have voltage and current. So we can optimize those parameters to reduce the total amount of radiation that the patient is subjected to. And the way that we optimize those parameters is a lot of it is actually automatic. It's built into the scanner. We have automated dose reduction techniques. We have a certain software aspect to it. It's called CareKV. And what it does is it takes into account the patient's size. So we're able to input things like the weight of the patient. Also, the scan takes into account the soft tissue composition of the patient. So even from something like the topogram, it knows where more dose is necessary. So the scanner will actually change the amount of voltage, which is matched to what the patient should have based on their size, so that we achieve the optimal signal to noise ratio. And then we also modulate the current too, so that the current will determine how much X-ray we generate, and the voltage is the energy of the X-ray. And you want that energy to be optimized for getting the best contrast that you can get. And the amount of X-ray generation, like after a certain point, it doesn't make sense to generate more X-ray. You only need a certain amount to make a diagnostic image. So as long as we can get good image quality from the lowest dose, that's what we do. And our dose reduction techniques are very strong. We do employ them. We have pediatric specific protocols too, but we do apply those strategies, and we achieve pretty low doses overall as a result. So.
And that's again across all 9 of our EDs, is that right?
Yeah, most of the sites use all MedStar sites. Okay, every MedStar hospital uses at least one of three dose reduction techniques, and
Cool.
those include things like automatic gain control, or automatic exposure control, the dose modulation according to the patient size, and also we use iterative reconstruction kernels, so we can take a noisy image and we can make a better image quality out of something that was originally noisy. We do some additional tweaking. There's a little bit of there's some little magic, hocus pocus going on in the background, but we do use some image dose reduction techniques. Every hospital will, yeah, all of our CT scans in MedStar.
That's
And a
great.
question for the magic behind the scenes, Rocky. So, for example, if we had ordered CT abdomen pelvis for rule out API, would the radiologist be getting notified by the text it's a kid and then reviewing the clinical to reduce the area of scanning, or not necessarily?
We need to prospectively inform the technologists where we need to scan. So our routine scans, abdomen, pelvis, do encompass the whole abdomen and pelvis, and I think we could probably still further optimize that by just telling the technologist, hey, you don't need to go up all the way to the diaphragm in this scenario. I just want to know about the appendix. But the problem, I'll tell you, here's the thing. When we do look for the appendix, I still kind of prefer a full abdomen, and I'll tell you why. Many times we wind up discovering some alternative diagnosis. So I've seen kids with right lower lobe pneumonias, and we would miss that pneumonia had we not gone up to the dome of the diaphragm, right? So like we usually do cover a wider range. I'll tell an example of how that might be useful. The limited field of view, we scan through a very limited range, would be if we know for sure that that's what we need to look for. Like let's say that we scanned the patient and there was motion and we need to rescan them, or there was something non-diagnostic, and or we need to take a second look. Or another unrelated disease would be like if we worried about a spondylolysis. Let's say that we're looking at the spine and we're thinking, oh my gosh, the x-ray kind of looks like there's a spondylolysis there. Let's just do a CT. Then we can scan just those two or three levels of the spine. L4, we'll scan it L3 through L5, L4 in the middle. We know that's where we need to go. The problem with the abdomen, with appendicitis, is you're venturing out into the wild, wild west. You don't know exactly what you might run into. And so I do wonder that sometimes if we want a full differential rule out, then it might be better to have a little bit of kidney in there, a little bit of the liver, gallbladder, right? It might be something else, but it depends on what we're trying to answer. If you really, really only need to know the appendix, then we can collimate the field of view. Yeah.
That's super helpful. Tammy, I think we're at the end of our time. Do you want to summarize for us?
Yes, so some key takeaways. Let's all pause before ordering imaging in our Peds patients especially. Remember to refer to the clinical risk and imaging decision tools and this new AAP policy statement and the tables to help with your decision making. Let's always remember shared decision making with our parents and caregivers. And lastly, documenting and even referring to the risk stratification tools, the policy statement, your shared decision making, documenting everything in your note. And also, I'd say some future opportunities for all of us to consider, improving access, the ultrasound, like we talked about, actual policies at our other MEP sites for use of rapid MRI for like shunt failure and appendicitis as well.
And if I missed it, just to add to that, I think using the Peds telehealth consult service sounds like a fantastic opportunity. Great. And then in the chat, we can close with this comment by Dr. Gaylor. Mentioned that his practice is to always call the ultrasound tech and tell them that they want to be in the room for the scan. And he finds that greatly increases the sensitivity. He's able to look himself and encourage a really comprehensive and lengthier scan, which I think is a great point. Well, thank you to our panel.